All right, this next lecture is going to be on articulations, or also just commonly called joints of the body. So articulations are points of contact between bones and bones, or bones and cartilage, or it could be even bones and teeth. So a general rule of thumb is the more mobile a joint is, the less stable it is. So if you compare the shoulder to the hip, shoulder is a lot more mobile, but it's less stable. The hip is a lot more stable and it's less mobile. So functionally, we're going to classify joints in three ways, and they're classified by how much they move. So some joints are immovable. They're called synarthroses. So a synarthrosis is an immovable joint. A joint that moves just a tiny bit is partially movable. It's called an amphiarthrosis. And then a joint that moves freely is called a diarthrosis. Most of the joints that you think of when you think about joints are going to be diarthroses. And then structurally, we can classify joints in three ways. Fibrous means they're held together by dense regular connective tissue. Cartilaginous joints are held together by cartilage. And then we have synovial joints, they're classified as synovial because they have a fluid-filled cavity called a synovial cavity and a joint cavity. And you have the surface of the bones that are interacting with each other kind of encapsulated by this cavity and capsule. So more on those as we go through this. So what we're going to do is start by going through the joints, looking at their structural classification. So fibrous joints, there's three subtypes. There's a suture, which you're familiar with. So a suture is a joint between skull bones. It's classified as a synarthrosis, meaning it's immovable. Then we have a syndesmosis, which has a little more connective tissue than a suture. And these are slightly movable, so we'll call these amphiarthrosis. The best example we have are the interosseous membranes between the radius and ulna, or the tibia and fibula. Then we have a unique case called a gomphosis. So this is defined as a cone-shaped peg fitting into a socket. And this is a synarthrosis, but the example that we have in the human body is the teeth. So the teeth fit into sockets, and that's actually considered a joint, and it's called a gomphosis. It's a type of fibrous joint. So moving into the cartilaginous joints, we have synchondroses and a symphysis, if you're talking plural. So synchondrosis just means they're held together by hyaline cartilage. These are synarthroses, meaning they don't move. So the examples that we have, the epiphyseal plate, I know you don't think of that as being a joint, but technically it is because it's bone to bone separated by cartilage, by hyaline cartilage. And then where the ribs meet the sternum, these costochondral joints. So we have hyaline cartilage there that you're aware of, and these should not move. So they're classified as synchondroses, hyaline cartilage, and they don't move, so they're synarthroses. Symphyses are held together by fibrocartilage, which you know is really strong. So we'll start with the obvious one. The pubic symphysis is this joint right here between the fronts of your hip bones. And these are classified as amphiarthroses because you get a little bit of movement there. Not much, but just a tiny bit of movement. Then also your intervertebral disc are considered a symphysis because they're connected by fibrocartilage, and you get a slight degree of movement. Then that brings us to synovial, and this is the major type of joint we think of when we think about joints of the body. So looking at the structure of a synovial joint, it has an articular capsule, which is all this, just encapsulating the joint. So there's an outer fibrous part to it, you can see here, and then this purple region would be the synovial membrane. And inside this synovial membrane is going to be synovial fluid. And so we call this the synovial cavity or joint cavity. So this is where the fluid is. So the synovial fluid is there because it helps absorb shock and lubricate the joint, and also gets nutrients to this cartilage here. So remember the articular cartilage that we have at the ends of bones. And chondrocytes need a way to get those nutrients. So the synovial fluid allows nutrients to get in there. So other things associated with synovial joints, we have articular cartilage that we were just talking about. That's this hyaline cartilage at the ends of the bones to kind of cushion them. We have ligaments. Ligaments, by definition, are dense, regular connective tissue that connect bone to bone. So this could be a ligament right here, connecting bone to bone. And there's also a blood and nerve supply. And in addition, we have some other stuff. We have tendons, which, as you're well aware, I believe, connect muscle to bone. You're seeing one right here. So muscle to bone is tendons. And again, that's dense, regular connective tissue. We get fat pads or adipose tissue at strategic places around joints. This is to cushion them. Like you see this adipose tissue here and here. That's for protection. You get bursa. Bursa are sacs of synovial fluid, kind of like little water balloons, strategically placed at various places around joints to help cushion and reduce friction. And then some of these bursa become really long like this. And when you get a long bursa surrounding a tendon, it's called a tendon sheath. But the concept is the same for bursa and tendon sheath. They're kind of like water-filled balloons that are there to reduce friction and absorb shock and protect. All right, so now we're going to focus on movement. So movements of synovial joints can be classified by how many planes of movement they move in. So all synovial joints are actually classified as diarthroses, which means they're freely movable. But some obviously move more than others. So if a joint just moves around in one plane, around one axis, like let's take the elbow joint, for example, all you can do is flex and extend that. That's uniaxial, so it moves on one axis. If you take another joint that can move in two different planes or around two different axes, that's called biaxial. Example might be the movement that you can do between the metacarpals, or let me say the better example would be the phalanges and the metacarpals. So if you take like your index finger, you can move it forward and backward. You can move it side to side, but you cannot rotate it. So that's the two axes. So that would be biaxial. Multiaxial means you can do three planes of movement or around three axes. So if you take something like the shoulder joint, you can move in the sagittal plane back and forth. You can actually move out to the side in the coronal plane. Then you can also rotate it, and that would be the third axis. So that would be a multiaxial joint. So the types of synovial joints they're classified based on their structure. And so we're going to talk about 6 major types of synovial joints. So starting with a gliding joint, also called a planar joint. There's not much movement here, even though it's still considered diarthroses. So just envision the joints between the carpals. You could also use the tarsals as an example. So these bones just kind of slide back and forth across each other. So that's why they're called gliding joints. They don't really move around an axis, so it's called a non-axial movement. A hinge joint would be like the elbow. So a convex surface fits into a concave surface. So you get the trochlear right here fitting into the trochlear notch, and you get that nice movement there at the elbow joint. All you can do is flex and extend it, and that's one axis of rotation, so it's considered a hinge joint or uniaxial. A pivot joint rotates around a structure. So a good example of this is the joint between C1 and C2. So you have the atlas, then you have the dens of the axis fitting in here, and that atlas can rotate around. Just envision shaking your head no, back and forth. You're getting rotation at that C1, C2 joint. And again, it's uniaxial because that's all it can do. But that's called a pivot joint because it pivots around a structure like the dens. A condyloid, sometimes called ellipsoid joint, it's kind of similar to a hinge, but instead of having more like rounded convex surfaces, they're more oval. So you get more movement. So oval convex surface fits into an oval concave surface. The example they're using here is the one I was talking about earlier between the metacarpal and the proximal phalanx. So if you kind of take your index finger, you can go forward and backward, side to side. That's a condyloid joint. And then, very unique example, a saddle joint. Similar to a condyloid on some level, but the best example we have is the joint between the trapezium and the first metacarpal. So basically this is going towards your thumb. So envision like if you're thumb wrestling that movement that you're getting, or hitchhiking, sticking your thumb up, that is movement at that saddle joint. And it's biaxial because you can go side to side, back and forth. And then lastly, ball and socket. We have some major examples of these. So a rounded shaped head fits into a socket. So the big examples are the head of the humerus fitting into the glenoid cavity at the shoulder, then the head of the femur fitting into the acetabulum of the hip bone. And so these are the most movable joints because you can get movement in 3 planes. So you can go in the sagittal plane and the coronal plane, and then you can also rotate. So we're actually going to start naming the movements now, and that's one of the things we're going to finish up with. So movements at synovial joints. So there are specific names that are important. So back to just the gliding. We just call this gliding movement. If you talk about the carpals just kind of sliding past one another. So we'll just call that gliding, not a big deal. So moving on to the more important movements. So angular movements where you're changing the angle of a joint. These are going to come in pairs for the most part. So flexion versus extension. So decreasing the angle is flexion, increasing the angle is extension. And that for the most part, if you start in the anatomical position, most of these are going to be in the sagittal plane. So I'll show you some pictures in a moment. Abduction versus adduction. This has to do with movement away from the midline or towards the midline. Think abduction away from the midline, adduction towards the midline, like you're adding to the body. So, and this is usually in the coronal plane. We'll go through some examples of that also. Then hyperextension is just if we extend beyond the anatomical position. Some joints do this naturally, others don't. And then lateral flexion could be the trunk movement or even just your head. If you kind of turn your neck so your ear touches your shoulder, that would be lateral flexion of the neck. You could also, if you just bent over to the side, that could be lateral flexion of the trunk. So pictures. I'm going to start here at the elbow joint. So if in this direction, you are decreasing the angle. So this would be flexion of the elbow. If you come out this way, you're increasing the angle. So it's extension. All right. So we go to the neck. So starting in the anatomical position, put the chin towards the chest. That's flexion. Coming back up because you're decreasing the angle here. And coming back up, extension. And then if you extend beyond the anatomical position, it's hyperextension. So let's do the knee. So decreasing the angle here, this would be flexion. Increasing the angle, that's extension. Lateral flexion we talked about, this could be the trunk or the head. Then the wrist, we have flexion because you're decreasing this angle, extension coming back up this way. Then beyond the anatomical position would be hyperextension. All right, so moving on to the abduction, adduction. So raising the arm like this, abduction, going away from the midline, bringing it back down towards the midline of the body, adduction. Same thing with the leg, abduction going away from the body, adduction coming back. Talking about the wrist, abduction going away from the body, adduction going back towards the body. Then if you're just talking about spreading the fingers, if you envision a midline of the hand, spreading your fingers out is abduction, bringing them back in, adduction. So one that is not shown here that I would like to bring up, and you're going to have to use your imaginations here. If you move your shoulder joint, like if you're reaching out to shake somebody's hand, that actually would be called shoulder flexion. A lot of people get confused on that one because they think about the arm as you're increasing the angle between like the abdominal area and the humerus. However, that is called shoulder flexion, like you're reaching your hand forward, your arm forward to shake somebody's hand. So you have to think of that specific movement as decreasing the angle between the head and the humerus. And so that would be shoulder flexion. So shoulder extension would be like if you're moving your hand from out or arm from out in front of you back to your side. And then hyperextension of the shoulder would be if you went beyond and actually kind of brought your humerus back behind your body. All right, so other movements, circumduction. there's a combination of flexion, abduction, extension. Adduction, a picture is worth 1,000 words. Here, I'll show you a picture. And rotation just means that the bone is rotating. So we have some great examples of this, like with the humerus, it can rotate from side to side. If it rotates away from the body, it's called lateral rotation. Back towards the body, medial rotation. Sometimes it's called external and internal, respectively. And you can do the same with the femur. So if you rotate your hip like outward, that's lateral rotation of the hip. Rotated inward, that's medial rotation of the hip. So circumduction this is different than rotation, but if you kind of put your arm out to the side and kind of made a circle, that's called circumduction. You can do the same with your leg. So that's circumduction. This is not rotation. Rotation would look a little bit different. So the elbow is bent so you can see it more pronounced, but where you're actually getting the rotation up here at the shoulder. So lateral rotation is rotating outward, medial rotation inward. This might be better, you may be better able to understand this one, where you just kind of rotate the hip outward so your foot faces out. That's lateral rotation. Bringing it back in, medial rotation. But remember that rotation is actually occurring up here at the hip joint. Then you could also have rotation of the neck, where you turn your head side to side. So special movements, we have depression versus elevation. Just has to do with upward or downward movements. So depression, some examples we have, like the shoulder girdle, pulling your scapula down would be depression of the scapula. Pulling it up would be elevation. You could do the same thing with the mandible. So if you close your mouth, the mandible comes up, that's elevation. If you drop your mandible down, that would be depression. And then we have protraction and retraction. So I know I put some other terms up here because sometimes you will see these. I don't want to confuse you, so you can just ignore these. So we're going to call this protraction and retraction. Protraction is forward movement. So this person right here is protracting his mandible, is pushing it forward. Retraction is backwards movement. So retraction of the mandible would be pulling it back. Now we can also get protraction and retraction of the scapula. So if you pulled your shoulders forward, again, rotated your scapula forward, like almost like hunching your shoulders, that would be protraction. And then if you really pulled your scapula back, that would be retraction of the scapula. So then we have dorsiflexion and plantar flexion. This has specifically to do with movements at the ankle. So plantar flexion is probably the easiest to remember. Just think planting your foot down on the floor. So standing on your toes, pushing your foot downward, that's plantar flexion. Dorsiflexion would be moving the top of your foot upward, like trying to stand on your ankles, or standing on your heels. Then we have inversion, eversion. So inverting your foot means turning the sole of the foot inward. Eversion means moving the sole of the foot laterally. So inversion, moving the sole of the foot in. Eversion, moving the sole of the foot outward or lateral. And then a couple more, pronation and supination. The way they drew this picture or made this picture, it kind of looks like they're talking about rotation, but this is different. It's better if you have this pronation and supination done if your elbow is bent. So try bending your elbow, putting your palm down, facing down. That's in a pronated position. Then if you turn your palm to face upward, that's supinated. So it's kind of like in the anatomical position, your palms are in a supinated position. But you can go back and forth. So pronation, supination. So starting in the anatomical position, this would be in a supinated position. If you turn your palms to face backward, that would be your pronating. And this movement occurs at the radio-ulnar joints. So this is not occurring up here at the shoulder. So opposition would be basically taking your thumb and touching other fingers with it, kind of like you do when you're writing with a pencil or pen. And reposition is the opposite, like if you were to drop a pen or a pencil. All right, so what I'm going to finish with is just running through the anatomy of the knee joint, because it is a really important joint. It has a lot going on, very specific anatomy. So this is the front of your right knee, and here's the condyles of the femur. Here's the condyles of the tibia. And so a couple of features that the knee has that are important. So it has a lot of ligaments. These two right here are called cruciate ligaments. They make a cross. So this is the anterior cruciate ligament, or ACL. which is in the front. PCL, or posterior cruciates, in the back. But the cruciate ligaments, front and back, anterior, posterior cruciate. On the sides, we have what are called collateral ligaments. So on the lateral side, we have the lateral collateral ligament. On the medial side, we have the medial collateral ligament, sometimes called the MCL. This would be the LCL. And then lastly, the other structures that are important are these discs right here. These are called menisci, and they're just rings of fibrocartilage. So you have a medial meniscus and a lateral meniscus. Looking at the back view, very similar. The condyles of the femur, you get the posterior cruciate you see right here. Here's your menisci, ACL right there, and lateral meniscus, medial meniscus, and your medial and lateral collateral ligaments. The only other picture I have here, and it's really not overly important, is just the shoulder joint. I just put this up to show you that there are a lot of bursa associated with the shoulder, because you get a lot of rubbing of the bones up here. So lots of bursa surrounding the shoulder joint.